thought I'd just kind of start just to talk a little bit about how I got to where I am today, because that kind of shapes my thoughts and stuff around physician-assisted suicide and some of the things that we've been reading in the media lately. And it's not physician-assisted suicide. It's been in Europe, is a lot of countries have accepted it and have laws around it. And then Canada, this is something that has been talked about a lot when there's been cases to the Supreme Court, and I'll talk a little bit about what the Supreme Court has decided and what that looks like. And then, yeah, we can open it up for discussion. So kind of early on I'm a Queen's alumni too, so I did my nursing degree here and did my master's here as well. But when I first started at Queen's, I was just enrolled in general biology and decided that after a short time that I was like, oh, well, what am I going to do with this biology degree? And I thought, well, I don't really want to teach because my sisters were both teachers. Being a little rebellious there. And then I didn't really feel like I wanted to do research at that point, and I thought, well, what else can I do with the science? And I really loved working with people, and I thought, well, nursing's a good place to go. So I kind of fell into nursing, but I really, really love my job. One of my very first placements was at St. Mary's of the Lake, and I had the opportunity to spend a few weeks in the palliative care unit there. And what I really enjoyed about taking care of those patients was that with palliative care, there seemed to get a sense of more holistic care. When I had placements at KGH, that was part of it, but there seemed to be much more of kind of a task focus. So someone had a broken hip, so that was the focus of care. Somebody had a pneumonia, so that seemed to be the focus of care. But when we were taking care of people in the palliative care unit, often those things didn't matter as much anymore, because the trajectory of where this person was going to be going was that some of those things didn't matter. We were just really focusing on comfort and caring for those patients, as well as the families that surrounded them as well. And so I really like the aspect of caring for the patient, but also there's a more holistic sense of caring for the community and the people around them as well. So that's got me thinking a lot more kind of like about death and dying and my interest in palliative care. And my journey in my career was I started working in KGH on an inpatient unit in oncology. I spent 7 years or so in the cancer center, so I worked on working with patients who had just been diagnosed, but also people along the whole trajectory of illness as well. And then after I finished my master's, I did a little bit of teaching, and then I came into to this job. And some people who've been around a while might know Kathy Colson. I'm not sure if that name rings a bell to some people in the community. She used to be myself. She used to be the clinical nurse specialist in palliative care, and she was a mentor of mine. So she actually shaped a lot of how I got into this role as well. And so when she retired, I got her job, and it was kind of a dream job of mine. So I'm very happy to be here. So I kind of wanted to start talking a little bit about what is a good death, and that is a very kind of fluid topic, and that's going to mean different things to different people. Often when we think about death, we're influenced by what we have experienced in our past. So if I look back at what my experience has been around death and dying, two of the things I think about was my experience with both of my grandparents who died, my mother's parents, that we lived in the same town as them. And they both died when I was in high school. My grandfather was diagnosed with probably a gastric cancer, if I think back to it now. And surgery and chemotherapy weren't an option because it had spread already. So he got diagnosed around March, and then he died around May. So it's a fairly short course. And so we were always given the opportunity to participate in any way in the care and being with my opa, as I called him. But when he was kind of close to the end of life, we were given the opportunity to come and visit him, and he was being cared for at home with nurses coming in, and then my mom's brothers and sisters were a big part of the care as well. And I chose not to, actually. So I made the decision that I didn't want to remember him in that way, and that was my choice. Like looking back, do I regret it? And I said no. I was probably, at that time, it shaped me and made me think about his death as being a good death. And then a couple of years later, my oma was living in the same home as us. She was living in kind of a granny suite, and so she too had like an end-stage heart failure, if I look back now and think about some of the symptoms she had. And she too died in our home. But again, I chose not to actually be physically at the bedside. But I think these stories really kind of shaped in my idea of what death could be like, because both of my grandparents died very comfortably, died in the places that they wanted to. They died with kind of family at their bedside, and they died in some ways the way they wanted to in terms of interventions and things like that. But not everybody may not have as comfortable of a death or a disease progression as other people, as we know, and stories that we hear. Often when people ask about or want to talk about death and dying, there's a lot of fear around death and dying, and we see that. When we talk about, or when we ask people that we meet, what are your fears around death? Often it's a fear, not fears about dying, but it's more how they will die, and fears around how that will affect the people around them. And so often we, in the work that I do too, we're encouraging people to kind of embrace the journey of death and dying, because that in tune will shape how they will experience their death. But it also speaks to the people that are around them as well. So I see that very clearly now in how I experienced my grandparents' death, and how that's shaped me and how I approach people around me that are dying, or even my own death. Am I completely not afraid of dying? No, I still have my fears around my own death, and I don't want to die. But there is a sense, right? There is a sense of a peace about that. This is part of life. I'm going to share a quote with you by Stephen Jenkinson, who maybe you've heard about. This gentleman is a social worker out of Toronto that's done a lot of work around death and dying, and he kind of teaches people about death and dying with kind of a spiritual slant to it, I guess. So this is something that he said that I've taken a lot of meaning from. The meanings of life aren't inherited. What is inherited is the mandate to make meanings of life by how we live. The endings of life give life meanings, a chance to show. The beginning of the end of our order, our way, is now in view. This isn't punishment, any more than dying is a punishment for being born. So really it's kind of about the journey, and how like now as we live each and every day, we're kind of embracing each moment that we have, and that's kind of how we approach death as well. It's like we are all dying, but it's about how we're living as we're dying, is the important thing. So I think I'm just going to switch to talking about, actually maybe I'll talk a little bit about palliative care and what that means, because that's where I work from, and then we'll kind of move into a little bit more of the chatting a bit about physician-assisted suicide. So palliative care, it is a scary word for some people. When people have palliative care, they say, oh, I'm referring you to a palliative care team. They're often, oh, I don't want to see you because that means that I'm dying. And we're trying to kind of change the way people approach palliative care. And one of the definitions that I really like is it talks about palliative care is aimed at the relief of suffering and improving the quality of life for people who are living with or dying from an advanced illness. Okay? So I like that definition because it talks about living with and dying from, right? It's not just about dying from. It's talking about improving quality of life, because that's a big part of what we try to do. And it's not, often people think about palliative care, often it's surrounded about cancer, right? Well, it's much more than that. People can die of lots of different things as well. And it also should include people who are bereaved as well. So after someone has died, the community and the family around them, we're caring for them as well. So we can move beyond that. So I like that definition because it can be working with people and caring for people at lots of different stages, even when they're first diagnosed. And that's kind of like what we're trying to do, is trying to share with people that we're kind of experts on quality of life as people are have an illness and have a terminal illness as well. Does anybody have anything they want to share, or any questions at all right now before I can? Yeah.
I just wanted to find out what determines that someone is palliative.
Palliative, for sure. Usually when somebody is deemed palliative, usually they have a terminal diagnosis of something. Mm-hmm. And that can vary, right? So like somebody who has an ALS diagnosis is pretty significant, and we kind of know what that trajectory is like. An example I'll have is, I remember when I first started working at the cancer center, I met a woman who had metastatic breast cancer, and she was just diagnosed with the metastatic part at that point. And that was probably about 8 or 9 years ago. And probably just last year, I kind of re-met her again. I've seen her kind of intermittently throughout my career, but just last year she died. So she lived with this metastatic cancer for like 9-10 years, right? So again, palliative care usually is someone with a diagnosis that is terminal. But again, that could mean someone might live for 10 years, but it could mean they might live for a shorter period of time, right? Yeah.
Because it's kind of a bit ironic, we are all dying.
We
so,
are.
Right?
Yeah.
So
we are all
terminal. You know, that's, I mean, I do have when do we, like, what really is that switch over to say it's palliative, right?
For sure,
That something is terminal, well, our life is terminal, so.
Yeah, I agree.
It's unfixable.
It's unfixable, right? And often we see that because some people we think about cancer again, we think about people receiving treatment, they're receiving palliative chemotherapy. So what does that mean too, right? That means that this chemotherapy is not going to cure them, but it's going to modify their disease in a way that might give them a better quality of life, right? Yeah. Mm-hmm. So, we often say, well, that person is palliative. And we were trying to kind of say, oh, well, let's change that. Let's say they're receiving palliative treatment because we're focusing on quality of life rather than disease modifying features. Yeah. And so that's where like those definitions are, like they can be a bit fluid, and it becomes difficult to deem what would be a palliative person or someone receiving palliative care. And especially when we're talking about like physician-assisted suicide or euthanasia, which I'll define them in a minute. But if someone like who should get it, you know, like do they have to have a terminal diagnosis? What is a terminal diagnosis? Like people can have chronic conditions for their whole life. So are they considered, you know, would they be able to have like a physician-assisted suicide or not? So a lot of that is in flux. There's been a lot of stuff in the news lately, right? And I feel like we only get the Saturday paper at our house, but I feel like every weekend I open the paper and there's some little bit or some little article about physician-assisted suicide or what's been happening. So I thought I'd just talk about the difference between physician-assisted suicide and then euthanasia, just so that we're kind of clear when we're using those terms. So physician-assisted suicide is the act of intentionally killing oneself with the assistance of another person. Okay? So it's another person's providing you a way for you to end your life. It's a deliberate act, but euthanasia, on the other hand, is a deliberate action undertaken by one person with the intention of ending that person's life. So an example of assisted suicide would be a physician who prescribes a medication to a patient who uses the drugs to kill themselves. Okay. Now the physician would need to prescribe that medication for that purpose. So we know that physicians prescribe medications all the time. So if someone's on an opioid or a pain medication, you get a bottle of 50. If you take all of them, that'll probably end your life. But again, that would be more euthanasia because it's the patient deciding to take those pills on their own, not the way it was intended. But a physician prescribing medication for physician-assisted suicide would prescribe those medications for the purpose of ending that patient's life. An example of euthanasia is a physician who administers like lethal doses of medications to someone suffering from like severe dementia or maybe end-stage cancer, with the intention of ending her life. So the medications that that the physician would give. So euthanasia, the physician has to give the medication. Physician-assisted suicide, the physician prescribes the medication, but the patient actually takes the medication themselves. So that's the difference. You can see it's a little bit different that way. Yeah.
I have a question about what happened with my father-in-law a year ago. It was sort of a passive euthanasia. He had dementia, he had fallen, broken a hip, had the surgery. Fell and broke a femur, had a stroke during that surgery. So dementia, stroke, couldn't talk, eat, drink or anything. So it was a withdrawal of nutrients. Which put him in the ICU, but was just being transferred to palliative care when he died. But it was 11 days of, I guess, medication for pain for spasms. But it was, I don't know what to say when people say, how did he die? I go, by not doing anything. Because he had already told us he didn't want to ever move from his retirement home. Didn't want to go into a rehab. He didn't want to, he couldn't do the exercises. He couldn't remember he had a broken leg, right? So what is there a category for that?
So we talk about withdrawing things, right? So, it's kind of like someone's like has a breathing tube in the ICU. We know that that's keeping them alive. We physicians would say would discontinue that because we know that's keeping them alive if they weren't on that. So again, they say that's not euthanasia because they're just basically stopping the life supporting measure because the person basically wouldn't be able to do it on their own.
If they were sitting at home in their apartment, they would have died because they couldn't eat, right? Okay.
And then in the case of your father, we think about all the things that are kind of building up to the point you probably had a meeting or decision-making point when you decided, okay, where are we going to go here, right? So we think about what treatments are going to benefit him, what treatments are not, right? So yeah, you're withholding things. Maybe by withholding him, we might be causing his death to happen a little bit sooner, but we're not actually giving something to make him die, right? And it's a hard thing. And I know, like, I remember as a nurse working as well and thinking like, I gave that medication and that person died like half an hour later. Did I do that? No, I didn't do that. I was giving the medication because it was routine medication for their pain. That dose didn't kill the patient. They were dying. So but it is that kind of, that slippery slope, right? Yeah. So the case in Canada, that the Carter versus Canada case is the one that's been talked about in the paper. So basically, one piece of this, it's pretty complex. So one story in the midst of that is, so Lee Carter and his wife were one of the plaintiffs in that lawsuit, and it was Lee's mother, so Carter's mother, she had spinal stenosis, so that was kind of like a degenerative disc disease in her back, and she had a lot of pain, chronic pain from that. She was really independent, but really couldn't go to the bathroom by herself and needed a lot of care, was in a lot of suffering because of this pain. And she really wanted to die. And so they actually ended up taking her to Switzerland. Yeah. And were very quiet about it because they didn't want to make that, until kind of after the fact. But that's kind of the case that was kind of surrounding the whole ruling. And so basically the Supreme Court of Canada decided that assisted suicide would be legal for people who are competent. They have to have a clear consent, or clearly consents to the termination of their life. They have to have a grievous and irremediable medical condition. Okay? So what does that mean, right?
You can't fix it.
Right? Yeah. Including an illness, disease, or disability. Right? So that opens up a whole big, a disability, a disease, or a disorder. Does that include, it includes so many different things, right?
Can the disorder be mental?
Yeah.
As opposed to
and that's the whole
disease that you can see?
Right? Often we just think about things that we can see, physical things, but what about all that other stuff? You're right, the mental illnesses that we see too, right?
But you have to be mentally competent.
Yes,
You
right?
can have
So
mental
there's
health issues and still be competent, I think.
Yeah, so continuing, so it's going to be hard, because that's, as you know, it was supposed to come into effect in January, but it's been deferred for another 4 months, so the government still has some time here. But
Can you actually just read that again?
yeah, I'm going to read it again because there's a little bit more to it. So the person has to be a competent adult person who clearly consents to the termination of life, has a grievous and irremediable medical condition, which includes an illness, disease, or disability that causes enduring suffering that's intolerable to the individual in the circumstances of his or her condition. And they're saying that, I can't say, this irremediable.
Yeah.
Anyway, basically means that the condition can't be alleviated by any means. So they're in uncontrolled pain, they're agitating, like whatever symptom, right?
Is there a time limit? Like, can you say, 2 years from now, if I have a stroke and I'm a vegetable in the bed, could you please
Yes.
put me down?
Yeah. We talk about that too, but no, right now, like this is all they
It
have.
has to be in a very short period of time. It can't be
Well, Canada, right?
2 years ahead, say.
Yeah. And I'll talk about Quebec too, because Quebec, as you know, has a Death with Dignity Act, or it's called Death with Dignity. I can't remember what the act is called, but they actually have a law around physician-assisted euthanasia. Actually, Canada's one is, as a globe, is talking about physician-assisted suicide. So, but the one in Quebec says no. You can't say in 2 years from now, if I can't make the decision, I need somebody to do
You could
this for me.
change your mind in 2 years.
Exactly, and you can't have somebody else make the decision for you. You yourself. And all the laws, kind of like Oregon, which I can allude to later, like I think mostly in Europe, you have to make that decision yourself. Although now in Europe they're talking about children, right? They're talking about pediatrics, right? Yeah. So I didn't read a whole lot on that actually, but I know that's the conversations about children and are talking about that as well. Yeah.
That's really complicated.
It is. Yeah. So in Quebec, I'll talk about Quebec because they're saying that how Quebec has made their laws might be something that Canada's going to look to. And again, so in Quebec, you have to be 18 or older. You have to be a resident of Quebec. So they put that clause in because they didn't want like people from Ontario flocking to Quebec and saying, okay, I want this.
Right.
Okay.
I see.
They were calling it travel euthanasia, like that's what we would call it. Whereas like in Europe, obviously people can travel there and get, such a, right? Like that seems to be a good place to go.
I think in Oregon you have to be resident.
You do as well, yeah. Yeah, in Oregon you do as well, yeah. So most places are,
Okay.
And there's other states, I just chose Oregon because most of the research has been done around that place. So in Quebec, they must be suffering from a serious and incurable illness. They have to be in the later stages of the illness. Must be experiencing constant, intolerable physical or psychological suffering. So again, it doesn't always have to be physical. Someone could be suffering like psychologically related to that. And then the suffering that can't be relieved in a manner that the patient deems tolerable. Okay? Which is interesting,
You
right?
could have electric shock therapy, and if you say I don't want to have electric shock
Yeah.
therapy for severe depression, then that's something I won't go through. Wow.
Yeah. I think in Quebec, I didn't actually find it, but I've heard that in Quebec you have to have a referral to like palliative care. Like that's part of the care. So if you put this request in, then you need to talk to someone. Like there's more here. It says, so the patient has to be of sound mind and capable of making that decision. They must sign and date a formal request, a written request. And a doctor must assess them over a period of time. So they can't just go to one doctor and say, I want this, and then it will be done. And then there's a second doctor that has to examine the patient as well. So there's 2 physicians that have to kind of sign off on this. The doctor may only end the patient's life with, there's certain medications that they'll use. So there's kind of a suicide kit or a euthanasia kit that they'll use.
Really?
Yeah. So it's kind of determined how they'll do it. And then the patient can bring an end to the procedure at any point. So the patient can make the request, but at any point they can say, no, I don't want this. Okay. Physicians who don't feel that it's within their belief system to grant the request can just they must refer to another physician.
Just
Yeah.
opt out.
Yeah, they can opt out of it. Yeah, and then one of the stipulations is not allowed to request a future euthanasia, you know, like, which I think, like with ALS as well, we know where that might go. Like, you know, like we say, well, my quality of life is good right now, but in the future when I get to this point, that's often the way we want to do it, right? If I get to this point, that's what living wills are, right? You know, often a living will will say, you've written a document saying, if I get to this point, that's what I would want.
And I think with dementia, especially people who are still competent early on in a process, but haven't an aggressive Alzheimer's diagnosis, are competent to make a decision now, but they can't later because they're not competent.
Exactly, yeah.
And that's when the family, with my father-in-law, it was the brothers all had to do it because he hadn't been competent for many years.
Yeah,
But we knew his wishes for
Exactly.
many years before.
Yeah. And that's another piece that I was going to bring into to talk about too, was just the whole idea of advanced care planning, right? To talk, and it goes beyond just writing it down. Like to talk about it with your family members and say, you know what, this is what I would want. Because sometimes that document, even if it's written, but the family didn't know about it, and all of a sudden they read it, they're like, oh, I don't want that. I want it. And now they're the ones making decisions for a parent. So it just, the whole idea of advanced care planning, sharing your wishes, is a really important thing to do. Yeah.
But if you do have a living will
Yeah.
and you do
Yeah.
say all this, it's not
Yeah.
like you can apply, you know, like
No.
say you have a stroke or
Yeah.
something and you
Yeah.
said, I want no artificial means,
Yeah.
you know, and I don't
Yeah.
wanna hang around.
Yep.
So, you know, I've had a stroke, I'm just
Yeah.
lying here.
Yeah.
Please assist, you know, can you-
Yeah. You
Or,
could write,
or
yeah.
euthanize
Yeah,
me
you-
because I can't assist.
Yeah.
Okay, but
Yeah.
so if
She-
I'm in that state,
Yeah.
who knows about my living will and who has
Yeah.
access to it?
Yeah.
To actually, like, is there like, do you,
My children do in my
Yeah.
case, so somebody has to know, I would say.
Yeah, and that's the whole thing about sharing your wishes. You
Yeah.
have to let people know what your wishes are and where those documents are. Yeah. But in a living will, you couldn't say, I want to be euthanized if. You
So
actually, it has to come from your
but
your
if you
mouth.
have a living will today, right?
Yeah.
When then you have two children who might
Yeah.
disagree with how to
Yeah.
apply the living
Yeah,
will.
yeah,
That happens today and
definitely. Yeah,
But if
Yeah.
they agreed,
yeah.
they couldn't terminate my life.
No, and
Or,
usually
you
what
know,
we
I
would
couldn't,
say.
I couldn't be
Yeah.
euthanized
Yeah.
because even though I
Yeah.
put it down of sound mind.
Yeah.
But here I am, and I could live for a long time.
You can live
just
for a long
lying.
time, yeah.
Of course, I'd starve to death, that's the problem.
Yeah,
Yeah.
that's
If you had no, that's where it
where
comes in.
we were.
Yeah, so it's
Some
pretty,
people don't wanna
yeah.
watch you do that.
Is the starving to death a common choice? I've heard that.
What was that?
Is refusing to take nutrients a common choice?
In dementia it is. If someone has really advanced dementia, often it's difficult to feed them, and often their malnutrition is one of the ways that they die is because
So they're not actively choosing it then?
No, they're probably not.
Well, some of the cases
Yes.
where if you feed and
Feed
they
them
open
and
their
they're-
mouth versus,
yeah.
there have been some cases about that, about
Yeah.
offering food on a spoon on a mouth, do they eat versus
Right.
do they feed
Feed
themselves?
And
themselves,
there's
and then
discussion in what
Yeah.
way is it reflex and in what way is it
Is it
actually.
a desire to live?
Yeah, for sure. And we talked about that. Yeah, we're actually.
Oh my goodness. And people with Huntington's and stuff. People
Yes,
who,
yeah,
there have
yeah.
been people recently who starved themselves to death at a younger age rather than go through
Yeah.
that. So.
Yeah.
And that's a whole other, and then you get into the whole discussions about do you feed or not feed, and that's like, and with dementia, it's a whole different, it's a very big discussion about putting in feeding tubes and things like that to someone who may not, it
Just
will,
pull it back out, right?
exactly, right? Yeah, and then and so that usually it comes to the point where someone develops a pneumonia or some other thing, and then they decide, you know what, because they're really ill from this, we're gonna let nature take its course, and this is the illness that probably will end their life. Like, there's lots of tough decisions to make at end of life. Yeah.
Wow.
Yeah. And so I think that's one reason why euthanasia and physician-assisted suicide has been brought to the forefront, was like, look at how messy it gets at the end of life. You know, can we avoid that by doing this? Or.
But then, like, are we trying to, in a sense, find a solution to a problem that, you know, or we're looking at, like, my case might be that, well, no, we need to actually do better at end of life care, so that we don't have
Yeah.
these whatever scenarios.
Yeah.
And the solution isn't that everybody should just take their own life at a certain time so that we avoid then having to find a different solution. I mean,
Yeah, I
that's
agree.
that's
Yeah.
how school.
And I'm biased, oh, go ahead.
You know, I was just
Yeah.
gonna say, it's up to the person.
It is.
Choice,
Yeah.
yeah.
It
Well,
is.
but you can say that, but if I don't have much choices, then of course I'll go for the suicide. But if there was good care, end of life care available,
pain
or
control,
I might
good
not
whatever.
kind of
Mhm.
do that. So,
Yeah.
so to just say, well, it's my own choice, but you know, my choices are limited by the opportunities that are there.
Yeah.
So, and in what time but am I too depressed to kind of really even think about other solutions? So,
Mhm.
in that depressive state, I say it's just going to be easier, let it end.
Yeah.
And how much was that a choice, or
Yeah.
was it just, in a sense, forced on person?
Yeah.
tricky.
How
Not
available
easy.
is palliative care? Is
Yeah.
there a waiting list for palliative care?
No, actually, so right now, referrals from palliative care, if you're in the hospital, you're seen the same day. If you're like an outpatient for a cancer diagnosis, you're seen probably within 2 weeks. For access to palliative care for non-cancer diagnosis is a little bit more difficult.
And what about pain management outside of palliative care? Is
Yeah.
it an issue?
It really depends on your family doctor and the physician or the caregiver that you have caring for you and how comfortable, you know, like, and I think that's the piece. So I think there's a big push right now for education for frontline caregivers to become more aware of what palliative care is and some of the symptoms. There's a big push for earlier referral to palliative care so that people are seen laid earlier and not really close to the end of life when there's lots of complexities. Yeah.
Do you believe that all pain can be cared for in that?
I don't believe we never promise people that we're going to take their pain completely away.
Yeah, you can't, no matter how much. I mean, you give them a morphine dose
Yeah.
to do it, it's going to end their life.
Yeah.
I mean, I've
Well, not-
watched that,
yeah.
and I mean, they always say, oh, well, we can make it easy for them, we can make them quiet and comfortable.
Yeah.
We can't
Yeah.
in some cases.
In some cases, it becomes really difficult. Yeah, an example is really close to home because we're following this gentleman now is like end-stage renal disease. Like someone has decided to stop dialysis. Most of the time, the toxins that are getting rid of during dialysis build up, and people kind of go into a coma, and they die within 5-7 days. It's kind of the norm. Where there's a small population that the opposite happens, where they get more agitated, they get more. The toxins kind of do the opposite thing, and we're kind of dealing with that now, where it's really difficult to kind of keep him not very agitated, and he appears to be in pain. So then we talk about something like, okay, we're more worried about his comfort, so we may sedate him to the point that he might not be able to communicate with his family, but then he's comfortable. Okay, and I'll talk a bit about that. So we talk about palliative sedation or sedation at the end of life too, and people feel like, you know, that might be hastening death. So we're causing them to be in a coma, or less aware of what's going on to a point. But there's a study that was done, I think in BC, and they looked at groups of people who had palliative sedation versus people who did not. And the people with palliative sedation actually lived longer and more comfortably than the people who didn't get palliative sedation. So we don't believe that it's actually hastening death. It doesn't decrease the rest rate or anything like that. It's not.
That's so
Yeah.
why.
Yeah.
I'm taking up a bed, my
Yeah.
kids are coming and visiting me and
Yeah.
worrying about me and feeling
Yeah.
guilty.
Yeah.
They leave me alone. Why?
Yeah. Yeah.
They're
Yeah.
longer.
Well,
with
yeah, like the
sedation.
average goes longer, but you're more
Taking up
comfortable.
OHIP dollars.
Yeah, but you're more comfortable.
Which aren't
right?
very-
Yeah.
But if the point is to keep
Yeah,
you comfortable
comfortable,
for
right?
the time that
Yeah.
you're
There.
needing
Where the
die,
yeah,
and
yeah.
then and not be in
Yeah.
pain and
Yeah.
when you're dying, right?
Yeah. So like this gentleman I was describing, he's pretty agitated. It's very, very distressing for his daughter. She's like, she's like, do
Exactly. Yeah,
something,
she
do
feels
something.
upset.
So
Yeah,
we're doing
guilt.
stuff, right? So yeah, so it's better to sedate him to the point that he can't communicate than it, you know,
Just
and
to see him
than
agitated.
to see him agitated, right? So it becomes a balance.
But that's where I think
Yeah.
euthanasia is warranted because,
Yeah.
you know, you're stressing my kids.
Yeah.
I'm at no value. I'm
Yeah.
taking up beds
Yeah.
in the
Yeah.
hospital, costing, you know.
Yeah.
and
But then it
it's-
Well, but
makes
I would
it's a
argue
huge.
dying is a journey, as you mentioned earlier, right?
Yeah.
So let us do it.
And sometimes it takes more time, and
Yeah.
for whatever reason, it might take a few more days.
Yeah.
So,
And we understand that vigil at the bedside is very difficult, and I think that's one of the supports that we have to give to people is at the end of life when someone is not able to communicate, they're kind of in that coma and like, oh, the next day, oh, they're still here, and then you come back the next day, oh, they're still here.
Now, wouldn't
Like,
it
you know?
be better if they were in their home, if they,
Yeah, and it's a challenge actually to get
to
people
move people
be at
to
home.
their home?
And
And have a nurse
it's a whole other
visit or
conversation.
whatever.
Yeah. People can't get 24-hour nursing care in the home, so
No,
the family
no.
the family has
would
to
have
pull
do it,
pull in a lot of weight.
Yeah.
It can happen if you have lots of good support and family willing to do more, but it's a challenge. It's a challenge to get 24-hour care in the home. Yeah. As a palliative care group, like we feel that if you have good palliative care, you wouldn't need physician-assisted suicide. So if you can do it adequately, then you wouldn't need it, right? And I was surprised. I looked at some numbers. So in Oregon is the state that I looked at. 0.2% of deaths per year are a result of physician-assisted suicide, and they've had it for about 5 years or so. In the Netherlands, 2 to 3% of deaths a year are as a result of euthanasia.
10 times as many.
Yeah. And there again, and the difference is that Oregon's doing physician-assisted suicide, so the patient has to be able to take the medication. Where the Netherlands, it's the physician giving the. So, and they've been doing it for, I don't know, a long 20. I want to say a long time.
So once you're in palliative care, how long is the average that year?
I can't give you a number because we see people who are like walking around in pain, like they might be still getting treatment for their cancer,
But they're still getting palliative.
but they're still getting palliative care because they're having a high symptom burden. Yeah,
So they can be going on how long?
they could be. Yeah,
No, but how
Yeah,
long?
but
I mean,
you just mentioned
yeah.
9 years,
It just
right?
could. Yeah,
The
so
woman
someone
who
could
was
be living for
first-
10 years with
Yeah,
this,
exactly.
right? Yeah, and then but yet their quality of life is okay because they're able to see their grandchildren go to weddings, and it really
That's why we're
depends on
gonna
the
have
person.
marijuana
Yeah,
legalized.
yeah, and you know that legal, marijuana can help as well in for symptoms. You know, yeah, we have a big.
So in that palliative care situation,
Yeah.
you're probably seeing patients for appointments.
Yeah.
Right?
Yes,
So they're not in the hospital.
they're not in the hospital. Yeah, some people are in the.
And then
we see
there would
them,
be
yeah.
hospices, right?
Yeah.
So you deal with all of those situations?
Yeah,
Or
so
at home.
or at home. Yeah,
My husband was at home.
yeah, yeah.
And he had stomach cancer and
Okay,
was
yeah.
operated on, but
Yeah.
it had all spread.
Yeah.
So they sewed him up again.
Yeah.
And so he had palliative care until he died, which was like 5-6 months.
Yeah.
And they
Yeah.
came to the house.
Yeah. Yeah, that's very, and that's what happens. So like the palliative care here in Kingston looks like there's the palliative care unit at St. Mary's of the Lake. So that's an in-hospital palliative care unit that has 10 to 13 beds that can take people in. Yeah. There's a community palliative care team. So if your family doctor is not comfortable doing palliative care, then there's a community team that can come to your home and do visits in your home. So there's a few physicians that do that. If you're able to go to doctor's appointments and stuff, there's a team at the cancer center. So for that, you have to have a cancer diagnosis to go to. And there's also another clinic for people with kind of like advanced heart failure, advanced COPD, respiratory conditions, as well as one of the docs sees ALS patients as well. So the non-cancer, there are clinics available. And then in hospital, we don't have any particular palliative care beds per se, but we're a consult service, and that's the service I work with. So anybody in the hospital who needs palliative care or has symptom management issues, they consult our team, and we see those people all in the hospital and give recommendations, and often end up following them after they're discharged or etc. Yeah. So there's lots of there's opportunity, but we know that we're being stretched. we are being stretched just because of the population. This LHIN actually has the highest aging population in Ontario, the highest, most elderly population in Ontario is this LHIN. I don't know if you knew that, yeah.
Retirement capital account.
Yeah, it is,
Retirement
right,
capital.
yeah. So we
Victoria.
see, there's a lot going on in this area, yeah.
We should become experts in it then.
Well, it's true, right?
Lots
Well, I
of
think it's a
stuff to
blessing
work
that because the Queen's palliative care team, that group of physicians, is really the expert in this area. There's no other. There's little pockets of palliative physicians throughout in different areas. Like I think there's some in Picton, Belleville, kind of Brockville area, or even north kind of Smith Falls and Perth. But Queen's is kind of the team that everybody goes to for advice and stuff like that. So yeah. So it's really complex, right? It's not just a kind of a cut and dry. I've made this decision. Let's move forward. So I can understand where they're struggling to kind of come up with a decision within the government, but I don't know. I haven't made a decision yet how I feel about it.
Do you think that generally doctors are on board for that? How many, doctors accepting?
Yeah.
that? Is there a pushback?
I work with 5 or 6 palliative care physicians, and I think they're about half and half. Half of them are like, I'm okay with it, I don't want to do it though. I want to do palliative care, and I don't want people to be worried that I do physician assisted suicide as well.
You wouldn't
right?
want to get that name.
And then I think half of them are like, no, I really don't agree with it. I'll refer someone else, right? I was part of a conversation with them not that long ago, and where they were discussing the whole, if this comes into effect and it becomes a law if it becomes a law that this is acceptable, do we have a duty to refer? So if I'm not comfortable to do that, I have a duty to refer to another physician who might be. But do I have a duty to inform? So if I'm seeing a patient for the first time who's got a metastatic cancer and it's not looking good and their time is short, do I have to tell them that one of their options is physician-assisted suicide? Is that
Changes
true?
the tone of the
It
conversation.
totally changes the tone of the conversation, right?
Yeah.
And I kind of got I was like, wow, yeah. I don't feel comfortable with that. That's the piece that I don't feel comfortable with. I'm like, I don't believe, and this is my personal opinion. I didn't believe that was. I wouldn't want to be able to offer that as a treatment to say, you know what.
But can you inform me if I ask?
Yes, definitely.
And I think people will ask.
Yes.
There is a duty to refer and to inform if people ask. No question
And I
about
think
that.
people are becoming more educated consumers when it comes to medical care, and they know, and they can read the newspapers, and if they're in that situation, they're gonna say, what can you offer me?
Yeah, people are. Yeah, I would say weekly we get asked about physician-assisted suicide. I just want to. I just want to do them.
In that sense, with the doctor,
Yeah.
it's very similar to the issue of abortion.
Yes,
Very
people have
much
talked
so.
about that.
Yeah.
Very much so.
3 doctors, wasn't it, that used to have referred
I was
for
gonna say, right
Oh,
there,
yeah.
that
abortion
is
way
the-
back
giving
when.
sounds
information.
very much
Yeah.
like
Yeah.
Giving in, some doctors
Yeah.
refuse to give information and
Yeah.
it's
Yeah.
offering that as an option or
And someone talked to me too about is physician-assisted suicide going to go down that slippery slope that kind of abortion did, where all of a sudden it's accepted and so it's done
it becomes more
routinely,
acceptable.
becomes very more acceptable and routinely. Where I don't think that's the case with physician-assisted suicide. If you look at the numbers that I shared a little bit about,
Well, but I do think, again, that people will make these decisions or come to these conclusions. That's what I want, in part because of the unknown, of not really knowing what could be out there in, say, palliative care. And the only thing that we might kind of, anyway, right, that could be, anyway. So, again, when is it a choice because by default, and that is in some respect a problem, right?
Yeah.
How much money are we putting into palliative care? And this idea that it starts earlier, so that it isn't this idea that, it's the last 3 days of your life or something, and so of course everybody who then hears that they're, anyway, right? Like if we accompany people along this period, right?
exactly, yeah.
but yeah, if one of the options, oh, you can just end it now, and how much money do we put into whatever resources?
Yeah,
Like
yeah.
that.
In the new hospital, how large will the palliative care section be?
I think there'll technically be more beds, but I'm not sure the funding for the beds will be there. So sometimes there'll be physically the space for more beds, but
Sorry.
it really becomes about what the government or the ministry will fund.
And then you're aware that Hospice Kingston
Yeah.
wants to open the facility
Yeah.
in 2017?
Yeah.
So would there be sufficient staff to?
I think right now the way that's going to be staffed is through like home care, like CCAC is my sense, is like home care nurses and then volunteers. So again, it'll be a different. I'm not sure what that would look like. Yeah.
We read a book for our church book club called Being Mortal.
Oh,
I
yes.
told go on it,
I
and
haven't
I'd
read
suggest
that one.
anybody who's dealing with anything other than perfect health, read that book for themselves or their family members, because he does bring palliative care in one chapter talking about, I guess in the US it's palliative or treatment, rather than combining the two together, like it sounds like the Canadian model's a bit more useful that way. But it's very good. It's talking about quality of life and when is enough, and what to do in the processes of just aging in general.
Yep.
So it's a very, very good book.
I've heard it's a very good book. Yeah. And I think that when in making decisions about life too, we're thinking about, in these moments, yes, quality of life it's really important. And we make decisions at different points in time, but things change. Things are fluid, right? Like
There are 4 questions in the book, and he says you have to ask this at any time in your life when things are changing. Do you want to be resuscitated? Do you want to be intubated? Do you want to do this? Is there quality of life? What do you want to do? And you ask yourself these, every time there's some major event or someone asks on your behalf, asks you these questions to say, yes, this is now, I have no quality of life. Some people just say, I want to be able to watch sports and eat ice cream. And if I can do that in my wheelchair or with my respirator, feed me ice cream on the side of my tubes or whatever, they're happy, right? So it puts a good spin on that.
Yeah, and it's very different for different people. Like, and depending on different cultures too, it's really dependent on or religious background, what quality of life means, right? Yeah, for sure.
Do we have enough palliative care doctors?
And I think that's where it's. Oh, in Kingston.
Are they
yes.
overrun with
Yeah,
people?
they're busy. They're busy people.
Yeah.
Yeah.
And we're only aging faster and faster. I mean,
Yeah, exactly. And I
so
think
it's not
that's
growing.
the kind of push to get. They do a course twice a year with family docs across the Lynn again, just to say they offer a palliative care course twice a year, just to get more physicians, more nurse practitioners and stuff, kind of on board, saying let's become a little bit more comfortable with this and how to keep people as comfortable as possible. Yeah, and keep people in their homes, But I think there's room. If we had more, they'd have a lot of work. They'd have enough work to do. That's the idea. Yeah.
I think with more people aging more rapidly, more population, the question of money is going to be very important.
Yeah.
How much can we afford?
Yeah, and they're doing a redesign, like a look at palliative care, and they've done kind of a cost analysis, and they feel like if someone has earlier palliative care, it actually costs less than if someone didn't have palliative care as early on, because of the conversations and the discussions and the way the treatment and movement goes. Not to say that they don't get adequate treatment, but maybe some of those unnecessary things that are done aren't done.
I don't understand that, how you, if you have palliative care earlier, how that
That helps.
at home.
Well, if you have pain control and you can still keep moving and keep healthy and have a good
Yeah.
appetite,
Yeah.
you will go downhill less quickly than if you didn't have good pain control and were sitting somewhere not
and
eating
maybe
and not exercising.
Yeah, and the cost, maybe that's in less hospital stays,
yes.
you're not coming into emerge all the time to have we're talking about pain specifically, let's say it is pain's the issue, you keep coming into emerge to get assessed or because you're not having good control. So if you have palliative care involved, the likelihood that you'll have those emerge visits is probably less because you have more access to care.
And like what Jill said, that because we're not trying to fix things anymore and do tests and try out things, that then those are often very costly kind of things, I assume, right?
Yeah.
Compared to
Maintaining some quality of life.
and then just a different outlook.
Different.
What can we do to make you more comfortable and more comfortable, not just in the vegetable for
Yes,
big
yeah,
mistake.
not, yeah,
But, you know, by,
exactly,
you know,
yeah.
like people being at home and, yeah,
Yeah.
as you said, not
Yeah.
going to.
And one thing we like to say is like palliative care doesn't mean no more treatment,
Yeah.
right? Palliative care may include antibiotics for a pneumonia that's causing a lot of discomfort. It may include antibiotics for a urinary tract infection that's making somebody confused or uncomfortable. It may include an MRI to look to see if there is any more bone mets, because you know what? Maybe radiation is going to help with that pain medication or that pain in that certain spot where there's a new bone met
Well,
metastases,
maybe I don't
right?
understand palliative care. When you say if you've
Yeah.
got a urinary tract infection
Yeah.
and we can, I mean, you're gonna get better from that quite
Yeah,
frankly.
you are. Yeah, so
So-
you can treat that.
Oh, okay.
Your cancer is still killing you, just not the uterine.
Not those intermittent
It's
things, right?
secondary,
Yeah,
it's
yeah.
secondary
Yeah.
thing.
Yeah. Yeah, so palliative, yeah, so I think often people think of palliative care being the last kind of like weeks to days of life. Palliative care can become involved way before that. Yeah. It doesn't just have to be when there's no disease modifying treatment. We can work alongside those treatments that might be controlling your disease, yeah.
And if it keeps you at home, it's way cheaper than being in the hospital. Like, that's the thing, is if you're
Yes.
looking at being the last week or two in the hospital versus the last month or two in the hospital, right there comes
Yeah,
your costs.
That's what they're thinking about in terms
Yeah,
of cost.
but it's very expensive for the
Yeah.
family to keep you at
Oh,
home.
exactly.
Yeah.
People
And,
have to
and
give up
that's
their job
a
and-
huge part.
To
Yeah.
pay for the nurses to come
Yeah.
and, yeah, and the equipment.
Yeah, and that yeah, the caregiver burden is a huge thing to think about, and I think that's often when people are wanting physician-assisted suicide or euthanasia. A lot of the reasoning is behind caregiver burden, saying, well, I don't want to get to the point so that my family is burdened by my illness and by what I'm going through.
And I think that's valid.
It's valid.
No matter what options there are, I think that if the person feels that way, really valid.
I mean, even employers are starting to offer compassionate care or leaves to look
Yeah.
after your aging parents and things, so that's gonna be helpful.
Well, the
to
government
people,
just
too.
like extended that. It used to get
Yes.
like what, 8 weeks or 2 months or something, but now it's
Yeah.
up to 6 months.
6 months.
6
Yes.
months. You can get, it's just EI, but it's something, right? The
Yes.
government can approve that. Yeah. Yeah. I'm not sure what time we're at.
Almost
Oh yeah. Oh, there we are. We're 1 o'clock.
It's sort
Sorry.
of officially stopped here.
There we go.
If people wanna stay around or have any questions or things to discuss. Thank you so much.
Oh yeah, no
Melissa.
problem.
Yes, thank
Yeah.
you.
Yeah.
Really a good start to a good conversation.
Thank you for inviting me.
No more